Epidemiology. Agent factor: Plasmodium vivax, Plasmodium falciparum, Plasmodium malaria, Plasmodium ovale. Life cycle: asexual, begins when infected female Anopheles mosquito bites a person, injects sporozoites. Hepatic phase: sporozoids disappear within an hour from a circulation. Some reaches liver cells. Sporozoites become hepatic cystosomes in 1 to 2 weeks. Burst release merozoites. Erythrocytic phase: merozoites quickly destroyed, attach to the specific receptors on the erythrocytes, penetrate erythrocytes, trophozoites lysosome. Are formed. Erythrocytic phase end with liberation of merozoites. Duration of erythrocytic phase: 48 hours, Plasmodium falciparum; 72 hours, Plasmodium malaria. Asexual, begins when an Anopheles mosquito ingests the gametocytes while feeding on an infected person. Gametocyte continue further development. Stomach of a mosquito: 4 to 8 thread-like filaments, macrogametes. Resulting zygote within 18 to 24 hours becomes motile. Oocytes grows rapidly with numerous sporozoites. Sporozoites migrate to salivary gland. Reservoir of infection: human reservoir, sexual form, must harbor both sexes. Viable gametocytes: only known animal reservoir, chimpanzee. Period of communicability: as long as mature viable gametocytes. Malaria is communicable. Relapses: recurrence of the falciparum disappear within 1 to 2 years. Plasmodium malaria known to persist for 40 years. Host factor: age, no age immune to malaria. Sex: female, less incidence of malaria. Genetics: individual with sickle cell traits, mild illness of falciparum. Pregnancy: increased risk. Socioeconomic development: prevalence in the backward population. Housing: insect bites within the home, ill ventilated, ill lighted house. Population mobility: infected among migrating population. Occupation: rural, disease related to agriculture. Human habits: sleeping outside the door, refusal to accept the spraying of house. Immunity: influenced by immune status of a population. Environmental factor: seasons July to November, temperature 20 to 30 degrees Celsius, humidity 60%, rain provide breeding opportunity. Altitude: not found above 22,000. Drainage of seaways. Prevention and control: elimination of reservoir, early diagnosis and treatment, reduce morbidities and mortalities. Case detection: one microscope per 30,000 population at primary health care in rural areas and 50,000 population in urban areas. Treatment: anti-malarial drug, presumptive treatment, all fever assumed to be malaria, only practical and effective approach. Surveillance workers administer single dose of chloroquine phosphate. Blood smear is obtained, reduction of mortality. Radical treatment: surveillance workers should return to the patient to administer radical treatment, aim at complete cure of malaria. Vivax, chloroquine and primaquine. Falciparum malaria, artemisinin based combination therapy. Other northeasterns uncomplicated. Mixed infection artemisinin, Plasmodium malaria, Plasmodium ovale, severe complicated treatment, quinine. Radical treatment, mass drug administration, best method of curbing transmission, interruptions of transmission with the help of chemotherapy, avoided in children under 5 years. Breaking the channel of transmission. Anti-larval measures, physical drainage of filling, deepening, flushing, management of water level, chemical larvicides over breeding places, oiling the collection, biological using Bacillus sphaericus, anti-adult measures, residual insecticides, space spraying, individual protection. Protection of susceptibility, personal prophylaxis, health education, malarial vaccine.